Welcome to the SCI Forum podcast. This podcast was produced by the Northwest Regional Spinal Cord Injury System in the University of Washington Department of Rehabilitation Medicine. The Northwest Regional SCI system is dedicated to improving the lives of people with SCI through excellent patient care, research, and education. To learn more about our podcasts and videos or to make a donation, go to sci.washington.edu.
Hello and welcome to the Spinal Cord Injury Forum podcast. My name is Jeannie Hoffman and I'm a clinical psychologist and professor at the University of Washington in the Department of Rehabilitation Medicine. We always have a lot of research going on in the Department of Rehabilitation Medicine and across the UW. And some of our core spinal cord injury quality of life researchers are starting studies, and we wanted to hear a little bit about these projects. So today I'm joined by Amy Starosta. Amy is a clinical psychologist and an assistant professor at the University of Washington, as well as an attending psychologist on inpatient rehabilitation at Harborview Medical Center. Amy, thank you for talking with us today. And I want you to just start and tell me a little bit about what your research is, what you're doing, what you're focused on.
Thanks for having me. I'm happy to talk today about some of the work that we've been doing, focused on how we can help people with spinal cord injury manage pain, both at the acute phase as well as hopefully preventing the development of chronic pain. Pain is a major secondary condition following spinal cord injury, and many people who are living with spinal cord injury say that this is one of the biggest issues that are impacting their quality of life. More broadly than just spinal cord injury, we've been learning over time that there are many different factors that contribute to the experience of pain, especially chronic pain, and that just paying attention to the biological pieces of pain means that you're really missing a lot of the really important factors that can both perpetuate or reduce pain over time. And so this is really focusing on the biopsychosocial model of pain and thinking about the way that we react to pain, the things that we think about pain, and the ways that we cope with pain can all greatly influence our experience of it. We have a lot of interventions that have been shown to be helpful and effective on an outpatient basis for people who are experiencing chronic pain. These are things like cognitive behavioral therapy, behavioral activation, acceptance and commitment therapy, and hypnosis. But we don't offer many of these things until pain has already developed. And so one of the questions that we wanted to answer was, could we offer some of these interventions earlier so that people have more tools that they can use to cope with pain during the early stages of their spinal cord injury? And that might either be a helpful resource for them as they move into more of the chronic stage of their injury, or may prevent the development of pain over time. So working with several of my colleagues who've been doing this work on the outpatient side, we adapted an intervention that specifically is looking at cognitive therapy enhanced by hypnosis and offering that to people during their inpatient rehabilitation hospital admission.
So where is this research going to take place and how long is it going to take for people to do this? Like what is that intervention?
We are just starting to ramp up our study, and we'll be recruiting individuals who are admitted to inpatient rehabilitation at Harborview with new spinal cord injury and experiencing some pain. What we're hoping to do, and what our previous work has been focused on, is offering people a 4-session intervention that's really targeted at developing coping strategies for dealing with pain, utilizing hypnosis as a way of amplifying the cognitive therapy that we're doing. Cognitive therapy really focuses on examining and understanding the way that we react to pain, and how that can amplify pain, and how we might be able to restructure some of our either thoughts or emotional reactions or coping strategies in a way that can reduce pain and increase our comfort. The hypnosis part of it is a way of automating some of those strategies and some of those skills so that you don't have to constantly be thinking to yourself, I'm going to think a different thought, I'm going to do some deep breathing, but rather that your body can start to do some of those things for you more automatically. We'll be recruiting for this study and enrolling people in the intervention probably about the next 2 years. And afterwards, we're hoping that we'll be able to come back and say if it was effective both immediately for people. So does it offer some immediate pain relief? We're also going to follow people for some time after their injury to see if those people who received the intervention have less pain down the road as well.
So that suggests to me that some people get this and some people won't.
That's right. So this is a randomized controlled trial, which is really the gold standard of how we evaluate any of our clinical interventions. That means that we need to compare people who got the intervention to similar people who didn't get the intervention. We do this in a randomized way so that we're reducing the type of biases that might come from somebody choosing to do the intervention versus choosing to not do the intervention. So, what this means for the individuals in the study is that some of them will get the intervention while they're on inpatient rehab. Some of them will get a different intervention while they're on inpatient rehab. And then, after they're done with that intervention, after we've been able to follow up with them down the road, we'll offer them the intervention that others received while they were on inpatient rehab. This gives us the ability to compare people both immediately and over time to say, really the only thing that was different between these two groups was that some of them got the intervention, and allows us to understand what the impact of the intervention is rather than the impact of all these other factors that individuals are often experiencing early following their spinal cord injury.
Most studies have a specific aims or a hypothesis that they're testing. So, what is your kind of hypothesis? What are you going in to test?
We want to know if we can offer interventions earlier in someone's rehabilitation process after spinal cord injury to help them manage pain and potentially reduce the development of pain over time as well. So, in order to do that, we are looking at two different interventions that have been used on an outpatient basis, and we're offering them during the inpatient stay. So, the real difference in this study is that we're offering things much earlier before chronic pain has developed as a way of determining, can we prevent chronic pain? Some of the interventions have been used on an inpatient basis before, and others are newer to that setting. And so we're looking at two different interventions, one focused really on understanding your pain and understanding the factors that contribute to your pain, and another that's focused more on adapting or changing the way that you respond to your pain. So we're going to be comparing these two interventions and making sure that people have access to both of them after the study is over.
So, it seems complicated to add an intervention to the inpatient rehab period because it is so busy. So, how do you know that you can even get people to do that?
That's a really critical first step and question, and one that we have spent the past couple of years really grappling with. We were lucky to receive funding from the Craig H. Nielsen Foundation to explore that exact question and the development of this intervention. So we did a pilot study. I think probably between 2020 to 2022, we were running a similar study in which we were just seeing, are people willing to do these types of interventions when they're so busy with their medical care, with their therapies, when they've got so much else going on? And do we have enough time to do this intervention? Everyone's schedule is really packed during inpatient rehab. Can we squeeze this in on top of everything else that they're doing? And the results from our initial pilot were that people were really eager. We actually initially planned to just recruit 50 people, but recruited way more than that. And were able to get more people involved in the study because there was so much interest. And most people were able to do at least 3 sessions of the 4, if not all 4. And people that finished the study said that they felt like it helped them. They felt like they'd be willing to keep doing it. So we think that that initial information is going to be really helpful in making some adjustments to make sure that the intervention does fit and is appropriate and jives with the flow of the clinical work on inpatient rehab, but also is very encouraging because while we weren't specifically looking at the effect of the intervention in that study, we did get to see that there were some positive impacts, both in reducing pain immediately, but also changing some of the ways that people reacted to pain as well, all of which we know are really important strategies for long-term pain management.
So it's great to hear that you already did that feasibility study and that you got that funding to do that. So did you get publications? Are there things out in the world that people could look at to learn a little bit more about what you're doing now?
Absolutely. There are two papers that we published from that initial feasibility trial. One is a summary of the broader intervention as well as the experiences of the individuals, kind of that summary of how much were people able to engage? Did they have any issues? And really, no, they didn't have any issues. There were no adverse events. And we found that people were really excited about it. We additionally did another paper that was focused on one individual who had a really specific needs related to the ventilation. And we weren't really sure if we would be able to do the intervention with people who were on mechanical ventilation. As you know, that's a major issue for many people early on in their spinal cord injury. And there's a lot of pain, there's a lot of anxiety and a lot of stress that goes along with the process of utilizing and weaning from mechanical ventilation. And so we did just a brief case example of working with one individual who was able to be really active and engaged with the intervention, even while he was in the process of weaning from mechanical ventilation. And so that published a paper specifically highlighting his experience just to show that these types of interventions can be offered to and helpful for people, even when they have highly complex medical needs.
That's great. If it's okay, we'll put links to those when we post this on the website.
Absolutely.
You mentioned that it's going to include people with a new spinal cord injury and that they have to have some pain, but are there any people that are ruled out, or are there any other criteria about, we talk about inclusion or exclusion criteria?
We tried to keep the inclusion exclusion as broad as we could, specifically because we know that many individuals with some of these marginalized identities tend to be excluded from research studies. And that's really a disservice both to those individuals, but also to the field of science, because we don't have a diverse representation of individuals. And so we only know when our intervention works for the people who are included in our study. We want this to be something that's really broadly applicable and generally available for individuals. So because of that, we really did try to keep things very broad. That to be said, we do have some additional exclusion criterias, and mostly they're focused on the cognitive ability to participate. And so we know that sometimes people have experienced a brain injury as well as a spinal cord injury, and that might make it so that their thinking and their memory is not strong enough yet for them to be able to participate in an intervention like this. Additionally, we are very focused on minimizing risk to patients. And so any individuals that have higher levels of risk of suicide, we are excluding those patients at this time. And with the hope that maybe in the future, this would be something that we could evaluate if it was safe for people who are at higher risk of suicide to be able to engage with.
What makes you concerned about this intervention with that population?
The hypnosis component is really a critical active ingredient in automating the cognitive adaptations that can be really helpful for managing pain. There is some very small evidence to suggest that hypnosis can increase suicidal ideation or risk of suicide. While we don't think that that's a major risk or a highly likely outcome, we the potential benefits of the intervention would absolutely not be worth increasing any suicide risk. And so for anyone who has had a suicide attempt or is at acute risk of suicide, we would not include those people in the study at this time.
Right. Thank you for explaining that. So if you end up finding that your hypotheses work out, that you can prevent pain from becoming chronic or that people are just doing better, what next? What happens after that?
We know that Harborview is a pretty specific place in terms of the way that psychology is integrated, both here and at UW Montlake as well. And so part of the question is, could we do this study? Could this intervention be viable in other environments as well? And so I think that the next steps would be reaching out to other locations who have rehab psychology, either in a similar way that we do or in a dissimilar way, to figure out, could we roll out this intervention, train psychologists, and make this available in other places, and it be effective. And if that's the case, then the next steps after that would be starting to develop a program for ways that we can train psychologists to do this work, because I think that this is something that would be very easy for trained psychology providers to learn how to do, and then make it more accessible for people throughout the country, not just here in Washington.
That's great. Well, I guess the only other thing is, can we plan to meet again in 3 years and actually learn about the results?
Absolutely. I'd be happy to share what I hope will be very positive findings in the future.
Yeah, this is great. Really exciting stuff. And I think, we need to find more interventions and help prevent some of that chronic pain that happens in this population, as well as lots of others. If it works here, maybe we can try it in some other groups too. All right. Well, thank you so much for joining me today, and we'll look forward to hearing about the results.
Thanks so much.
Thank you for listening to the SCI Forum podcast. To learn more or to make a donation, please visit sci.washington.edu.